Hi, my name is Danielle Weinberg, and I'm a third-year medical student at Florida Atlantic University Charles E. Schmidt College of Medicine. Today, I will be presenting a rare presentation of asymptomatic 2019 SARS-CoV infection in a Caucasian pediatric female. Our patient is an 8-year-old Caucasian female with no significant past medical history besides asymptomatic COVID exposure 3 weeks prior, with a patient-reported positive COVID antibody test performed outpatient 1 week prior to initial presentation. The patient was brought to the emergency department for acute onset of isolated horizontal double vision with bilateral lateral rectus pain on adduction of the associated eye that started 2 days earlier. The patient was examined and was found to be alert, awake, and fully oriented with age-appropriate behavior. Vital signs were normal, and initial basic labs did not reveal any abnormalities. Rapid SARS-CoV-2 nucleic acid amplification test was negative. Neurologic exam revealed esotropia of the left eye, and when testing ocular motor function, bilateral Duson's nerve palsies were noted, more prominent on the left. The rest of the neuro exam was normal and did not reveal any other cranial nerve abnormalities, weakness, gait disturbance, diminished sensation, or absent or diminished reflexes. Non-contrast computed tomography and magnetic resonance imaging with and without contrast of the head and neck did not reveal any areas of ischemia, hemorrhage, mass effect, midline shift, restricted diffusion, demyelinating lesions, or areas of abnormal enhancement. The patient was subsequently instructed to follow up outpatient. The follow-up occurred 3 days later. At this time, the patient had presented with bilateral symmetric lower extremity weakness, ataxia, and persistent diplopia. There were no bulbar symptoms, dysautonomia, or signs of impending respiratory distress. She was immediately sent to the hospital for expedited further workup, which included a lumbar puncture and treatment with IVIG for suspected Miller-Fisher syndrome. LP showed a protein of 100 milligrams per deciliter and a normal glucose level. Encephalitis and meningitis panels were unremarkable. Serum anti-GQ1B antibody was absent. The patient was immediately started on IVIG for 3 days, after which she started to show improvement. Fortunately, the patient continues to demonstrate clinical improvement in the outpatient setting with ongoing physical therapy. In the Information and Images section, Figure 1 shows the current understanding of the pathophysiology of Guillain-Barré syndrome and its variants, including Miller-Fisher syndrome. As you can see, GQ1B antibodies are associated with the Miller-Fisher variant. Figure 2 shows unilateral esotropia in a child, similar to how our patient presented. Figure 3 shows bilateral Duson's nerve palsies. While this presentation was similar to our patient's Duson's nerve palsy was more pronounced on the left. Miller-Fisher syndrome has been described in a small number of patients infected with COVID-19, with a median age of 55 years old. Our case demonstrates that symptoms of Miller-Fisher syndrome can present in the post-infectious course of COVID-19 infection in pediatric patients, even in the absence of severe COVID-19 disease. Our case also demonstrates Miller-Fisher syndrome can present in the absence of usual concomitant symptoms on initial presentation, including ataxia, areflexia, and ascending weakness. Furthermore, presence of an anti-GQ1B antibody is not necessary for the diagnosis of Miller-Fisher syndrome, as seen in our case. And interestingly, the absence of GQ1B antibody has been described in the majority of cases of Miller-Fisher syndrome associated with COVID-19. In conclusion, in acute or recent asymptomatic COVID-19 infection or known exposure, there should be a high index of suspicion for Guillain-Barré syndrome subtypes in pediatric patients with or without a typical presentation. Thank you for listening.